We are live.
Good evening, and welcome to Impact of the SCOTUS Reversal of Roe v. Wade seminar by the New York Academy of Medicine. It's truly inspiring to see all of you here this evening, taking the time at what is probably the end of a very busy day for many of you. I want to thank you for doing that and taking the time to address this critical issue with the fascinating panel we have this evening. I'm Ann Kurth. I'm the President Designate of New York Academy of Medicine. I'm a certified nurse midwife by clinical training, and so this is a topic that is near and dear to my heart, as it is to, I believe, many of you as well. Commitment to health systems that support people in their reproductive and sexual health autonomy is a bedrock of my own experience and perspective, and may well be yours. Preserving and strengthening, not restricting and penalizing these rights is crucial and a clear challenge given this SCOTUS ruling. Reproductive and sexual health care is a human right, and the impact from the Dobbs ruling is obviously going to continue to reverberate, and we'll be diving into that tonight. NYAM made clear our stance and support back in July, understanding that this is a public health crisis of the first magnitude, and affirming the value that access to health care should never depend on where you live. Unequal access will affect equity and reduce care for BIPOC and other structurally disenfranchised populations in particular. The impact on clinicians and providers will increase strain in states preserving these services. Shortly after the historic Supreme Court ruling that struck down Roe v. Wade, NYAM came together with other concerned health organizations as one of the founding members of the Reproductive Health Coalition, a wide range of health professional associations and allied organizations who advocate with a unified voice to protect access to reproductive care. There are more than 30 member organizations in the coalition, and work is underway to leverage our collective strength to protect everyone's right to reproductive care with dignity, autonomy, and privacy, as well as to protect clinicians' ethical obligation to provide care. This coalition commits to an evidence-based approach to policy and practice, as we always do at NYAM. At NYAM, achievement of health equity is our North Star, believing that all people and communities should have equal access to a healthy lifespan. We also recognize a need to be sustainable for the future, ensuring that healthcare remains accessible and comprehensive in the face of legal challenges, political polarization, questioning of science, and current and coming challenges such as pandemics and the unequal health impacts of climate change. I'm extremely grateful for the work of the Women's Health Research and Wellbeing Workgroup at NYAM, who put together this incredible panel this evening. And I turn it over now to the wonderful Dr. Danielle Laroque-Arena. Danielle?
Thank you, Anne. It's such a pleasure to see you and to feel so welcomed. And your leadership was known already, but it is such a pleasure to see your strong support for the work of the Women's Health Research and Wellbeing Workgroup. So my name is Dr. Danielle Laroque-Arena. I am a pediatrician, a senior research scientist at the New York Academy of Medicine, and professor of clinical epidemiology and pediatrics at Columbia University. I'm President Emerita of SUNY Upstate Medical University, and past co-chair of the Governor's Task Force on Maternal Mortality and Disparate Racial Outcomes, and most relevant for today's convening, the founder and co-chair of the NYAM Women's Health Research and Wellbeing Workgroup. I organize and will moderate this session. The Women's Health Research and Wellbeing Workgroup was founded to focus on the health and well-being of women and girls, with particular focus on maternal mortality and morbidity and disparate racial outcomes, addressing the root causes of why women of color bear the greatest burden of maternal deaths and morbidities, with the maternal mortality ratio for Black women 3 times the rate of white women at 41.4 per 100,000 versus 13.7 per 100,000. By the way, we don't do well worldwide for any of our women. And for the year 2011 to 2015 in New York City, an astounding number, Black women were 8 times more likely to die from a pregnancy-related cause than white women. We are here today to discuss the impact of the Dobbs versus Jackson Women's Health Organization decision and to discuss in detail its likely repercussions for the health and well-being of women and girls. I begin with a brief timeline relevant to our convening, which obviously may be unknown to many of you. Roe v. Wade, the legal case in which the U.S. Supreme Court on January 22nd of 1973 ruled that unduly restrictive state regulation of abortion is unconstitutional. In a majority opinion written by Justice Harry A. Blackmun, the court held that a set of Texas statutes criminalizing abortion in most instances violated a woman's constitutional right of privacy, which it found to be implicit in the liberty guarantee of the Due Process Clause of the 14th Amendment, which I quote, "Nor shall any state deprive any person of life, liberty, or property without due process of law." On January 24th of 2022, in July, right? I put January, anticipating of 24th of June 24th of 2022, Roe v. Wade was overturned by the Supreme Court of the United States in an astounding decision. On the same day, June 24th of 2022, the editors of the New England Journal of Medicine published the article "Lawmakers versus the Scientific Realities of Human Reproduction," stating, and I quote to you, "The just announced U.S. Supreme Court in Dobbs versus Jackson Women's Health Organization represents a stunning reversal of precedent that inserts government into the personal lives and healthcare of Americans," close quote. The article goes on to discuss the historical facts and concludes, and I quote, "By abolishing longstanding legal protections, the U.S. Supreme Court's reversal of Roe v. Wade serves American families poorly, putting their health, safety, finances, and futures at risk. In view of these predictable consequences, the editors of the New England Journal of Medicine strongly condemn the U.S. Supreme Court's decision, and we join in this condemnation." Following the ruling announcement, numerous groups, among them universities, national and community-based organizations, scholars, individuals, weighed in on the end of Roe v. Wade and its multitude of implications. The Women's Health Research Workgroup is among those groups and forwarded a 9-point plan to the president of NYAM, then Judy Salerno, and its board chair. Among them was the need to convene health professionals and the public at large to dissect the repercussions of this ruling and mitigate its foreseen negative consequences on the lives of women and girls. We present this forum in collaboration with our colleagues at the NYAM Library. I want to personally thank Paul Thierman for his leadership, and the NYAM Nursing Section, and I want to personally thank Allison Squire, who is the chair of that section and also a member of the work group, to raise to the forefront the importance of a societal focus on the health of women, birthing individuals, and the children they will bear. This forum is presented by health professionals who deliver care, public health professionals and others who understand the epidemiology and context of care, legal scholars who assist in the interpretation and impact of the laws enacted on the lives of individuals, and historians who help understand the journeys of the past and how we might learn from these to not repeat the mistakes of the past. The work group is infinitely grateful to both Judy Salerno in her NYAM statement, which Dr. Kurth mentioned to you, for their support of free dialogue and the use of the convening power of the New York Academy of Medicine to support the conscience of us all on the implication of the SCOTUS decision, but to do more, to rally us to act on behalf of and in partnership with women and girls and their families. Thank you for attending. We look forward to a robust discussion. Now, I will briefly introduce our panelists and ask you to refer to their bios for further details. Each panelist will present for 10 to 12 minutes, summarizing the impact of Roe v. Wade garnered from the analysis of their professional perspectives. Following the panelists' presentations, I will pose questions for conversation among the panelists. These questions will be guided by your questions posed in the Q&A. So please, as you listen, add those questions as you're listening to us. Also, these questions will come from the information shared by the panelists, of course, and the prior reflections of our work group members who have been very active in the planning of the session. As you use the Q&A function, as you listen to the questions. Okay. Oh, sorry, I now must go here. As you listen to the question, forgive me. Please note what is most important to you. By the way, closed captioning is provided, which is important to our audience. While we reserve the Q&A following the presentations, I begin with one to get us started. A question posed by a member of our own work group, and this is the question. As the panel experts, what would you like us to know? What are the main points to disseminate to the lay audience, and I added, and the population at large? So I will begin with our panelists. I will list them in order, and we will begin with Professor Sanger. Professor Sanger is the Barbara Ehrenstein Black Professor of Law. Her areas of specialty are contracts, family law, and abortion. Carol Sanger is an award-winning teacher and influential scholar of reproductive rights. Her most recent book about abortion, Terminating Pregnancy in the 21st Century, addresses the regulation of abortion and maternal conduct, surrogacy, and the law's relation to culture. Ms. Sanger has received the law school's Willis L.M. Reese Prize for Excellence in Teaching, Columbia University's Presidential Teaching Award, Social Justice Initiative's Outstanding Public Interest Faculty Member of the Year, and the Columbia Law Women's Association Myra Bradwell Award for her commitment to mentoring female law students. Christine Brandy, Dr. Brandy, is an OBGYN family planning specialist and steadfast advocate. And you see they've joined us on in video. A steadfast advocate of reproductive autonomy for BIPOC people who dismantles oppressive structures in reproductive health to help every person achieve their own reproductive justice. She currently serves as the Darney Landy Fellow at the American College of Obstetricians and Gynecologists. She serves as the board chair of Physicians for Reproductive Health, sits on several subcommittees for the Society of Family Planning, and is a founding member of Centering Equity, Racial, and Cultural Literacy in Family Planning. She proudly identifies as a Latina pansexual abortion provider. Dr. Wendy Wilcox, a dear friend and colleague, a member of the Women's Health Research and Wellbeing Workgroup, is the Chief Women's Health Service Officer at NYC Health and Hospitals. Dr. Wilcox previously served as Department Chief of Obstetrics and Gynecology at New York City's Health and Hospitals, Kings County, a busy place, I might add, where she established a performance improvement program to improve quality and patient safety for labor induction, management of obstetric hemorrhage, severe hypertension in pregnancy, and improve OBGYN emergency response code. Most recently, Dr. Wilcox was responsible for designing and implementing the New York City funded NYC Maternal Mortality Morbidity Reduction Initiative, which established the maternal medical home. For the pediatricians in the audience, you might that might resonate with the medical home for children. And this provides enhanced wraparound services for pregnant persons at risk for adverse pregnancy outcomes. In 2018, Dr. Wilcox served with me as co-chair of the New York State Task Force on Maternal Mortality and Disparate Outcome. And I hope we will be joined also by Leslie Reagan, who is the professor in the Department of History, Department of Gender and Women's Studies, and the Illinois College of Law. Dr. Reagan specializes in the history of American medicine and public health, women, gender and sexuality, disabilities, visual culture, and the 20th century US social history. That's a mouthful. In 2012, she was named a University Scholar, the highest award the university gives her for scholarship, teaching, and service. Dr. Reagan's most recent book is Dangerous Pregnancies, Mothers, Disabilities, and Abortion in Modern America, and it was published in 2010. Which has won several awards. So we will begin, and here we go. And I will go back to the question that we asked, if I can sort through this, that what would, Professor Sanger, as you begin, what would you like the audience to know?
Well, I have to tell you that you didn't need to repeat that for me, because after our little session where you said what the general question would be, I decided I was making that question my life's command now. You had said, what is critical to convey? And that's how I go through my teaching. What is critical for students to know, students or any audience to know? And I appreciated your pulling it together as our sort of theme. And I'm sure each of us have found an hour's worth of things to convey. But since we have, I think, 15 minutes, I've chosen 3 points, and we'll see if there's time for any more. The first is just to look at what Dobbs, which is the case that overruled Roe v. Wade, the full case is Dobbs versus Jackson Women's Medical, excuse me, Jackson Women's Health, Jackson's Women's Health Clinic, and what doesn't it include? Because it's meant to be every time there's an abortion case, the Supreme Court, every time there's a major abortion case, the Supreme Court sort of boldly says, and we think this decision that we've just written will take care of all the problems forever. Justice Blackmun did that in Roe. There's a hint of it in the subsequent important case called Casey, and Justice Alito was who wrote the Dobbs case, also seems to think that he's solved all the problems. But I want to suggest, no, there are years of litigation out there based on just what this case doesn't do. The second issue I want to do is talk about something about the midterms and the relation of the overturning of Roe to the importance, not just the importance of the midterms, but how some of them are playing out, particularly with regard to abortion prohibitions. And the third thing is the most important. I want to go back and point out some features of the Dobbs case itself, so that when you're talking to people, you will know what Dobbs really did. Yes, it overturned Roe, but it's how it overturned Roe that makes it quite treacherous or dangerous for other areas of law. And I'll explain that. But I'll just say personally, I don't care for the Dobbs case at all. I find it a very difficult case to teach. I haven't had to do that yet. But I find it has a sort of unpleasant tone, and is sort of unmerciful in its certainty about what it's holding. Now, you do want advocates to be absolutely certain, but the justices aren't advocates. And so I'll give you a few examples of what I'm talking about. But we in a moment. So what you can know about the holding itself, what the decision, the consequences of the decision of overruling Roe and Casey, is that there is no more constitutionally protected right to terminate a pregnancy, of a woman's right to terminate a pregnancy in consultation with her doctor. That was how Roe explained what the right to an abortion was. They added in the doctor was an inherent part of it, but it was up to the woman with consultation herself, not her husband, not a boyfriend, not her parents. If she was an adult. So it was they made very clear, and not a hospital committee, which I know might be interesting to some of you, because in the run up to the Roe decision, there were efforts at abortion reform. And one of the reforms, which was thought to be to increase the availability and accessibility of abortion, was to have a hospital committee made up of hospital staff members who would decide whether the patient qualified for an abortion. Now, qualified in what sense? We now, since Roe, the qualification was that you wanted one and you fit within you did whatever else the state said you had to do, but there was no qualification. in the pre-Roe days, it was a matter of mental health. You had to go before a committee and tell them that you were in severe mental distress, possibly suicidal, and that it was necessary to protect your life, in essence, to get the abortion. And this was thought to be a liberal proceeding, but it turned out that very few women over time got them because hospitals didn't want to be known as abortion, the Reno of abortions, by just letting women get them. So, but Roe came down. Roe was decided in 73, and it was just between a woman and her doctor. Okay, now I did mention the Casey case, and I think that's important to know. I mean, this is like cocktail conversation 107. So if you're talking to someone, you will be able to tell, you will understand the whole background. In 20 years after Roe was another case called Casey versus Planned Parenthood of Southeastern Pennsylvania. And Casey, everyone thought, was going to be the case that took down Roe. There was great hope for it by abortion opponents. And there was a conservative majority on the court. And lo and behold, when the decision was unveiled, it turned out that they did not overrule Roe. And this is an important reason why. Justice O'Connor wrote the opinion with two others, and she said, if I had been on the court when Roe was decided, I'm not saying I would have ruled for Roe, but I wasn't on the court then. I'm on the court now. And now in 1992, we have an earlier case that deals with abortion regulation. That's Roe. And she said, there is a doctrine called stare decisis. The rule stands, the earlier rule stands, and we must follow stare decisis unless there's a very good reason not to. And then she explained why we have this jurisprudential rule, sometimes called precedent, that a court, when it gets a decision, should look to see, has this court, not the same members of the court, but as the Supreme Court say, heard a similar case. And if they have, it should be examined very carefully to see that there's no reason, has anything changed that we should give it a different ruling. The basis of this is something called the rule of law. We feel we want, under our system, to have litigants and just ordinary citizens know that when a case is decided, it will not change just because there's been an election and a different party has come into power. So it's a very sort of steadying hand, and is a very important principle of law. First-year students always learn this, and it's important that they do, until perhaps now, but we'll come to that. So so Casey is the second case that upheld the legality of abortion. And when I say the legality of abortion, I'm contrasting it to the criminality of abortion. Prior to Roe, about 3/4 of the states had criminalized abortion, which meant that not the woman, but the doctor could be arrested if he was found to have performed an abortion. Okay, so now one of the questions is why Dobbs? Why is Dobbs the case that went to the Supreme Court? And why did Dobbs go then? Why was this the right time for hearing this case? And the two answers combine. What states were doing was the red states were gunning to be the state that brought down Roe v. Wade. It was like a badge of honor to say our valiant legislators were able to take down and reverse Roe with our statute. And so to do that, they would pass statutes that violated Roe v. Wade. So for example, Roe says you can't, you can have an abortion up to the point of viability. At the point of viability, the fetus is too developed, it's too much like a child or baby, and we think the state has a great interest in it at that time, great enough to ban abortion. So what states began doing was passing laws that said, at the time of Roe, viability was 28 weeks. By the time of this case, viability is about 24 weeks. But what the states started doing was passing laws at 6 weeks called heartbeat bills, because you can hear an electrical pulse of the developing heart, or 10 weeks or 20 weeks. And Mississippi passed one at 15 weeks. This is not viability. A child born at 15 weeks cannot, it is too young. You'll correct me if I'm wrong, to be even a preemie. The synapses aren't connected, and we don't have enough life developed. Okay, and the idea is Supreme Court will take our case with our bad law, and they'll say, well, we'll deal with your law in a minute, but while we've got the case here, we think it's important that we look at the underlying cases of Roe and Casey. And that's what they did in Dobbs. They said, yeah, we'll come back to the question of 15 weeks and whether that's constitutional. But in the meantime, well, we actually don't need to get to that question because we're finding Roe and Casey are the ones that are not constitutional. Roe and Casey, you can't have a case that's unconstitutional, but Roe and Casey are wrong. And this is what Justice Alito, who was the one who wrote the decision, said, our hands are tied in this matter. Roe and Casey were wrong from the beginning. They were, he says, egregiously wrong, and therefore they cannot stand. Now, and therefore we overturn them. But it's important to know why he said they were egregiously wrong. What was egregiously wrong about them? And some people thought that maybe it was, Justice Blackmun said, a fetus is not a person. So maybe the court was going to say, well, actually, we think the fetus is a person. And so that's the wrong, the egregious. No, what was egregiously wrong was that they rested on the existing doctrine of a right of privacy. So over 100 or so years, the court developed a doctrine of privacy that said there are different zones of protected space that people control as part of their own self-definition. And the state has no right to bust through these invisible protections like marriage. So the state can't tell married people what to do. Well, the example is in 1965, Connecticut had a law saying married people may not use contraception. And the court in that case said, well, we think there is a right to privacy that protects people in their marriages in the intimate zone of decision-making about their marriage. And so that case was called Griswold, and it led directly to Roe. So the right to privacy was held to be included within this zone of privacy. Now, when Alito strikes out privacy, and this is an important feature, he implicitly, some think, is offering any right that's founded in privacy to be struck down. So, such as contraception. Now, Alito himself said, this case is about abortion and only abortion. It doesn't mean you can go around looking for other rights that are grounded in privacy and strike them down, like contraception, like same-sex marriage, possibly interracial marriage. And interestingly, Justice Kavanaugh, who wrote a concurring opinion, said And he also agreed that this was limited to abortion. But Justice Thomas said, not so fast, not so fast. I think that it's time for lower courts to go out and find cases that have rights on privacy and decide, do they fit within this zone of now discredited privacy? So that's one of the questions about Dobbs. What is its, how far does it extend to other forms of behavior that the state may now regulate because it is not protected by a right to privacy? May I just check? I don't want to be going over the time. Danielle? Yeah.
Yeah, I'm obviously listening intently because your comments are so critical to our understanding, not only of what this does in terms of access to legal abortions, but also the implications for reproductive rights in general and the broader implications for civil rights, for
Yes.
privacy and autonomy. So
Yes.
I am giving you extra time to be able to ground our discussions, which will be followed. The next speaker will be Kristen Brandy, at what it is that we're facing with respect to health professionals and the community at large, and understanding the issues that are at stake here. So
Okay,
please
then
go
I
on for another few minutes.
okay,
Okay,
good,
and I will
good.
signal you, and Dr. Brandy will be prepared to, to move forward, and I will ask her and Dr. Wilcox to take from the streams of discussions that you are laying out so clearly for us as an attorney, and most of us are not attorneys, is to understand the law, to understand what it has done, and to see the implications in the delivery of healthcare to
Okay,
people that we are, responsible for. So thank you. I give you another few minutes.
okay, thank you, because that will let me get to a good place and something I want to explain. So one might say, well, wait a minute, Justice Alito, what about precedent? Why don't you have to pay attention to precedent as the court did in the Casey case? 3 conservative justices said, we're not overturning Roe because we have a precedent that is a competing rule. We're supposed to attend to whether there's an earlier decision that deals with the same subject matter as we have here. And Alito just sort of brushes precedent aside and says, it's very shocking. And I know in conversations with my colleagues, everyone's talking about, how are you going to teach precedent now? Is there precedent? Is he just inserting new rules to decide whether precedent applies? And the answer, I believe, is yes. And people were doubly offended because Casey was called precedent upon precedent, because Casey was an abortion case and it took Roe and then it affirmed Roe. So we have 2 precedents for the court to follow if it was of a mind to follow that doctrine, which is well practiced. But what I just want to get to is Justice Alito went off on an interesting section where he wanted to explain that unwanted pregnancy is really not such a big problem. And the reason I am focusing on this is in both Roe and Casey, and I'm not going to read out the quotes, but both Roe and Casey had a little discussion about what it means to have an unwanted pregnancy. And they both said it can bring great stress upon a woman. It isn't good for the whole family environment. They gave very thoughtful, about 2 paragraphs each, discussion of why this is such an important decision for a woman to have control over. And if I can just say as an aside, I always think it's worth pointing out that the difference between a wanted pregnancy and an unwanted pregnancy can be 1 telephone call. It can be 1 call from a boyfriend who says, oh, sorry, I didn't sign up for a baby. Done. you know, that the whole world that a person is living in, where they're going to have a little baby and it's going to love them, it is wiped out. Another is an employer calls up and says, I hate to tell you, but I have to pink slip you. She loses her job, and possibly she has another child. So the economic forces of that call. And then there's the call that she might receive from her doctor, giving her the results of a prenatal test on the fetus that has results that are unhappy, and she may decide not to go through with the pregnancy for that reason. So, but those were all examples of wanted pregnancies. And so the notion that there's just some kind of bad woman who goes around having abortions because, you know, it's hard to fill in that sentence because it's a slow day, you know, rarely. And I don't mean that it's always a tragedy, a tragic reason that a woman chooses to have an abortion. Sometimes it's purely economic, or it's she's not ready, or she doesn't think she'll be a good mom now. And so I think those are, oh, but I'm going back to Justice Alito and how he explains why it isn't such a big deal to have 9 months and gestate a baby, because you can put it up for adoption. And he has quite a long section on this about how there are many, many Americans looking for newborns, and that we even have a special law called safe haven laws. We have it in New York too. And I've written an article on safe haven laws, and they are a terrible way of placing a child for adoption. And they were passed. The idea is you can give your baby over to a fire station or a hospital emergency room, and they take it, and you don't sign your name, you don't put down who you are, and you can leave with impunity and anonymously. And the idea was behind them, every time a state had a truly tragic case where a baby would be thrown into a dumpster, the state legislature would say, oh, we need a safe haven law that will keep that from happening. Well, it doesn't, but it also means that a woman or girl goes through her whole pregnancy with no prenatal care because she's hiding it. She's going to sneak it into the fire station. So Justice Alito goes on to how wonderful these laws are. And in the oral argument, so did Justice Barrett. And so that's one ground, that you can give your baby up. And one of the lawyers representing the clinic said, but women who have unwanted pregnancies they have adoption now. Safe haven is a new thing, but they have adoption now and they prefer not to. And it's what I call the out there problem. Women say, I don't want to know my baby is out there. I don't want the pregnancy, and I don't want the child, and I don't want the history to follow me everywhere. Not so.
So Professor Sanger, we're going to hold other
Sure.
discussions, because what you've gone through, unfortunately, we have as health professionals encountered many of the examples that you have given. So I'm going to ask you to hold on your points, and you'll have an opportunity during the conversation among the panelists. And I'm going to ask Dr. Brandy to help us with the perspective in terms of reproductive rights of what she has heard in responding to your comments, but also in the perspective that her organization, her advocacy have brought forward. Thank you.
Thank you.
Sure. And again, thank you so much for having us and having this really important discussion. We had introduced me at the beginning. I just want to lift up some positionality statements that I am an abortion doctor. I practice in New Jersey, but I also represent several organizations that do work on a national level. And I'm also a person of reproductive potential, and someone that identifies with a lot of intersecting identities. Listening to Professor Sanger's conversation around law, I could listen to lawyers all day, and I feel like I do often. And I wonder always if there's an accelerated course for physicians that provide abortion, because we grapple with law every day as it applies to the patients that we see in front of us. And so it's always interesting to think about how law, from my lowly perspective as a physician, has such power to both help protect and, create justice in our world, and how it has the equal ability to be able to withhold justice and withhold, in my case, care from patients that need it. When I was given this assignment of 10 minutes to discuss what do I want people to know, it felt overwhelming, in that I hate hearing myself talk. So 10 minutes is a long time, but also there's so much I wish people knew at this moment. There's so much that I want to share about me as a person on the ground providing abortion care, as well as hearing from providers and patients across the country, how much I wish I could share in this moment. So I'll do my best, and I'm very fortunate to be followed by Dr. Wilcox after myself. So I hope will fill in all the gaps if I miss things. I'll start with the basics. If I had to choose one message, I wish people knew that abortion is healthcare. Surprisingly, it's something that I feel like I have to say a lot, because I think until now, people haven't really taken the time to understand how abortion is normal and boring and something that is just part of everyday evidence-based healthcare. That was before the Dobbs decision, and that exists now. It's something that is a critical part of healthcare, and something that I have always thought was a critical part of the way I provide my care as an OBGYN. I know there's several physicians listening in as well, that just like I provide prenatal care, just like I provide contraception care and gynecologic care, cancer screenings, to me, abortion is another day at the office. It's something that, my patients need, and I'd love to be able to provide them the full spectrum of the rest of their care that they need for themselves and to maintain healthy families. I think it's important for people to understand that abortion happens for a lot of reasons. And to me as a provider, it never really mattered why patients sought care. I usually don't ask people why they seek abortion care, because I want to be able to provide it for them regardless of the reason that they're seeking it. But often legal restrictions create rules and regulations about who gets care. There's a lot of conversation right now about what is a good abortion or a bad abortion, what even is an abortion. And I'll talk a little bit about that in a second, but I think it's important to name that there's so many reasons why people seek this care. And that many people that you know or have taken care of, if you're a provider of care, have had an abortion in their lifetime. It's projected that about 1 in 4 people have had an abortion during their lifetime. So it's something that it's actually pretty common. It's something that many people experience. And I think it's important to also understand that anyone could be at risk for an abortion. If you happen to be pregnant, if you have the ability to become pregnant, there's always a chance that you could either seek an abortion due to various circumstances, or potentially require it if there's a circumstance where a pregnancy is life-threatening, in which case there could be a medical indication to recommend an abortion. And we can talk more perhaps in the Q&A about what those conditions are, how that looks on the ground. There's also people that, whether their pregnancy is dangerous to them or their potential child that they would deliver after the pregnancy is completed, would have a very poor prognosis, and so choose to end their pregnancies. So I think it's very important to understand who gets an abortion. It's everybody. It's anybody from any walk of life. The vast majority of people that seek abortion identify as low income, as Black and Brown, as people that come from marginalized groups. And part of that, it may be related to the reasons that they're seeking care. And maybe it's related to other types of care that they are unable to receive due to marginalization and barriers to care. I think it's also important to recognize that abortion was difficult to access before Dobbs. Before Roe was overturned, many people were traveling out of state. About 1 in 10 people that sought abortion care before Dobbs had to already travel outside to a different state to be able to access the care that they needed. we talked recently about Casey and how Casey opened up a window for so many restrictions to come into play, where really, if you were a provider of care, the care that you were able to provide, and for patients, the care that they were able to receive really depends on your zip code. That I could be in New Jersey one day and provide care, and be in Pennsylvania and have to do something entirely different, perhaps going to New York, going to Virginia. Depending on where you live, the rules and regulations are different, which when I think about that in the context of comprehensive healthcare is not how it should work. I don't necessarily have different rules for providing pap smears or providing hysterectomies, or who gets a C-section, who doesn't. That doesn't change based on where you live, but abortion does. And drastically so for some folks. And that was before Roe was overturned. Now currently in Dobbs, I think the current projection is 15 or 16 states that either have 6-week bans or total bans on abortion. That has meant that 66 independent clinics have closed since Dobbs was overturned. And about 22 million people of reproductive potential live in the states that have overturned Roe and have abortion bans, so to speak. And so that's a lot of people. Looking at those numbers, about over 100,000 people got an abortion last year in those areas. So that's how many people potentially will be denied care this upcoming year. I also wish people knew just the chaos that exists right now in the healthcare system after this ruling. That you would think many people have heard the term abortion. It's on the news all the time. People talk about it in politics all the time. But the minute that Roe was overturned, there was a lot of confusion about what counts, so to speak. That there are a lot of conditions in medicine that have differing definitions from what lay people may use. And a lot of that confusion has come from the law, in that the law doesn't necessarily account for the individual person that is in front of me, the patients that I see every day. It may not say exactly what care is legal and what care isn't. It may have broad terms. So for example, some laws say if you end a pregnancy, that is an abortion. Technically, laboring and delivering a baby is ending a pregnancy. Ectopic pregnancy, managing that, which is a surgical emergency potentially, emergencies that can be life-threatening, that is ending a pregnancy. And so depending on the way the law is written, depending on the situation that patient is in, the conversation has been, how can we take care of as many people as possible when we don't necessarily know what the law says compared to what our medical recommendations would be. So we've seen a lot of confusion and chaos. We saw this in Texas during the time of SB 8 and are now seeing it in several states across the country, particularly those with very strict rules, with very few or no exceptions, that many people are being barred from care, not just for abortion care, routine abortion care, but also care that would impact someone's life, things like miscarriage management, ectopic pregnancy management. We've seen concerns about whether or not people can treat them or how sick someone has to be in order to treat them. There's been concerns about other types of care, things like in vitro fertilization or other assisted reproductive technologies, where often we are managing embryos outside of a person's body. And how do you store those embryos? And what happens if, the cooling process doesn't work properly and those embryos are destroyed intentionally or unintentionally? Are people liable? There's been conversations about medications. Many people it's been gotten more and more difficult to be able to access medications that people routinely take because they may or may not be related to abortion care. Things like mifepristone, which can be used to treat endocrinological, I can't talk today, can treat endocrine disorders. Misoprostol, which is FDA approved for like gastric ulcers. Methotrexate. My mother has rheumatoid arthritis and takes methotrexate for her arthritis. But many people across the country are having difficulty getting particularly methotrexate for various conditions that are not pregnancy related, because they also have a connotation around abortion. And it's not because people don't want patients to get care in some circumstances. Frankly, a lot of people are just scared. And this includes physicians, nurses, this includes pharmacists that are dispensing medications, that many of these rules don't say, who's liable and who's not liable. People joke, but it's true that people are like, I have to call my lawyer before I take care of a patient. Because we honestly don't know the risk and the liability in providing care that really should be routine. Things that it's not wavering in the evidence on how you manage an ectopic pregnancy, how you provide a safe first trimester abortion. There's excellent data on all of those things, that all that care can be incredibly safe. But we are being told that we cannot provide this care. And so I hope that we'll have an opportunity to talk later about some solutions and ways that we can manage this. But I think just to close that, Dobbs, I think, has lifted the veil for so many people about what OBs perhaps already knew, that abortion is part of routine care. And I'm hopeful, particularly for those of you that are not OBGYNs, that you're hearing this message and hearing about how this impacts you, how this impacts your communities, and potentially what you can do to help. Thanks for the time.
Thank you, Dr. Brandy. That was comprehensive and really eye-opening. We're fortunate that Dr. Regan was able to join us, and she is our historian. And just to recap for her, we did have Professor Sanger discuss the legal implications and the intricate discussions that revolved around the reversal of Roe v. Wade. And so perhaps and the question that I posed to the panel, as you know, because we discussed this yesterday, is what would you like us to know as a historian, the main points to disseminate to this broad audience who are certainly predominantly health professionals, but I hope they're members of the public and others who are listening in to understand the complexities, but what the main issues are from your perspective as a historian. Thank you for coming.
Thank you so much. My apologies for the time zone mix-up. So what I thought I could quickly bring to you is what I've learned about how the laws were enforced when abortion was criminalized in the 1860s and 1870s. One thing that's important to know is it wasn't always illegal. It was legal under common law. But I really looked down at the nitty-gritty about to see how were the laws enforced and what was the public health impact. And what I found was the laws always, of course, affected the people who were getting abortions, women who were getting abortions, and with disastrous consequences in terms of public health, but also in terms of their relationship to medicine and to the law. Because to enforce the laws, a new system was created in the early 20th century where coroners were trying to find the people who were responsible for abortion-related deaths. And that meant they wanted information from women themselves, from women dying of abortions, and to collect a dying statement from them before death. And they recruited doctors and hospital staff to be the ones who acted as the arm of the state in collecting statements from their patients, from coercing them. And so doctors, out of fear of losing their licenses, out of fear of being prosecuted, and because they were told to do this by coroners and police, they would report miscarrying women to police and also ask questions themselves. Who did this to you? How far along were you? Who was the quote unquote father? Where did they put the instruments? What did the instruments look like? And ask them to identify people. And if women refused, then they would sometimes threaten, well, I won't take care of you until you tell me, or threaten to take away the welfare benefits. This is something I found starting in the 1900s. It went all the way up through to 1973. And of course, we are now seeing this is happening again. And of course, it was happening before Dobbs, as doctors at public health hospitals, at public hospitals in North Carolina, for instance, came up with their own program to report birthing women for quote unquote delivering drugs to a minor. So we've had thousands of women already who've been incarcerated for pregnancy, miscarriage, and childbirth. The other thing that was developed as a method of enforcement as abortion becomes safer, along with childbirth in the 40s and 50s, was police raiding abortion offices or clinics and deliberately looking for people, not just who were dangerous, but for the people who were actually safe providers. Some of those were doctors, some were nurses, they were different people, and people who had been practicing and providing abortions for 10, 20, 30 years. And what they did was they conducted raids and they tried to capture the provider performing an abortion, capture the patient, patients recovering, patients waiting for their appointments. And you can tell it's like an open office and clinic if there's that many people around, and all of the patient records. And then arresting, taking the women to police stations, forcing gynecological examinations in order to collect evidence. And so the laws that, you know, when people have passed these laws, as in Texas, and say it's for the protection of women and they will never be prosecuted, that is impossible. They don't have to be prosecuted to be punished. And that is what I found in my research. The process of law enforcement and investigation is punitive in and of itself. And of course, that's the purpose. There is no way to have evidence of these so-called new crimes without the body and the words of women and the pregnant people who get captured in the process. So I expect that all of these methods of the past will be revived along with new methods. One thing that's different now is we have a very active anti-abortion movement that is very well versed in how to harass people and how to collect information, license plates, and all of the rest. And again, doctors, as Dr. Brandy just told us, are confused by the law, are afraid of the law, and end up complying with the law. There really needs to be an effort among medical professionals to understand their own status and their own power to make medical decisions and to assert it publicly and collectively. This was done by doctors in the 1960s and early 1970s that led to the decriminalization of abortion. But, you know, as I'm telling you, doctors, nurses, hospital staff found themselves being the enforcers. And I really do think this is something that's very important for people to think about and address and find ways to reject collectively. And I don't know if I'm at my 5 minutes or if I should continue.
Yeah, no, first of all, disadvantage of a webinar is I wish I could see the faces of the now 62 people, we had 66, who are engaging in this discussion. And the reason that we brought this to the forum of the New York Academy of Medicine is to exactly have the discussions to understand what the past was, what under 50 years until June 24th of 2022, where there was a reversal, what protections women and birthing individuals had, and what we are returning to. And I think, thank you for describing that. I am going to go on to Dr.
Thank you.
Wilcox, but I will call all of the panelists following Dr. Wilcox's presentation to come back together, because the focus that we have at the New York Academy of Medicine is twofold. It's equity and it is health. We are not confused about our purpose. It is about equity and it is about health, and specifically here, the health of women and girls. Dr. Wilcox.
Thank you so much, Dr. LaRoccarina. I really appreciate the introduction. I appreciate being on this august panel. You know, Professor Reagan just brought us back to the future, right? And it's clearly scary times. I'm an obstetrician gynecologist by training. And I also want to thank Professor Sanger for kind of laying out the legal brick road, so to speak. And I want to lift up what Dr. Brandy had said, which is that abortion is healthcare. It is healthcare. Abortion is healthcare. The very basic essence of the clinical management of so many health conditions including ectopic pregnancies, hemorrhage, septic pregnancies, pregnancies that might be complicated by heart disease, cancer, diabetes, and a whole host of just other medical conditions will be impacted by this recent SCOTUS decision to repeal Roe versus Wade. This decision to overturn abortion's rights calls attention to the complete and utter disregard of the Supreme Court to pay attention to the rights of women to control their bodily autonomy. What do I wish people want people to know? I'm going to talk about the disproportionate burden that Black women will bear from this decision to overturn Roe versus Wade. Professor Singer did talk already about how this is probably going to set the stage for impacting other decisions where privacy is called into question, such as contraception and perhaps same-sex marriage, maybe even interracial marriage. And so it's a very slippery slope. And so I don't necessarily need to repeat that. But then also I'm going to talk about our obligation as providers, leaders, and citizens of this United States to address the political and societal upheaval. It's been said that when white America catches a cold, Black America catches pneumonia. And so Black people have had to bear the burden of most health disparities. And research shows that even when insurance status and education and economic conditions are equal, Black people still experience a disproportionate amount of worse health outcomes. In other words, the very history of the United States and the development of healthcare from its inception has racism at its roots. In slavery, kidnapped fathers, sons, mothers, and daughters were forced into death camps. African farmers, artisans, and other skilled professionals were stolen from their homelands, and under bondage and threat of death, they built these United States. The Supreme Court strategically overlooks legal history, which reminds us with stunning clarity, specifically the terrifying practices of American slavery, including the stalking, kidnapping, confinement, coercion, rape, and torture of Black women and girls. As I said before, the birth of medicine and healthcare in America has its roots in slavery. As slaves were considered property, young physicians practiced their craft and experimented on enslaved people, certainly without consent or anesthesia. And this is really one of the first books that really talked about this, and it's widely known as in Medical Apartheid. It's a book by Harriet A. Washington, and she really talks about this history of medical experimentation on African Americans. And investments in healthcare or healthcare at all was not to protect the people, the enslaved people. It was to protect property. And as property, Black women had no recompense for rape. And as children followed the status of their mother, forced impregnation was a way to build a workforce and breed workers without having to purchase them. So in 1807, the transatlantic African slave trade was abolished. But Black men and women continued to be considered property, certainly devoid of bodily autonomy. And I want to share with you the following excerpt from a book called Birthing a Slave, Motherhood and Medicine in the Antebellum South by Marie Jenkins Schwartz. By the 1820s, planters and would-be planters were moving in large numbers to places previously unavailable for settlement and growing the fiber for sale in Europe and New England, where a textile industry was beginning to thrive. The extension of the so-called Cotton Kingdom required new laborers. As of 1808, when Congress ended the nation's participation in the international slave trade, planters could no longer import additional slaves from Africa or the West Indies. The only practical way of increasing the number of slave laborers was through new births. With so much at stake, Black women's reproductive role became politically as well as economically decisive. If enslaved mothers did not bear significant numbers of children to take the place of dying workers, the South could not continue as a slave society. It's not by accident that healthcare has become tied to employment. And as slavery came to an end, political views on the need to provide healthcare for Black Americans was largely viewed as no longer necessary. And we can see this viewpoint today in states, red states oftentimes, that have made the political decision not to expand the healthcare safety net. The World Health Organization defines maternal mortality as the annual number of deaths from any cause related to or aggravated by a pregnancy or its management, excluding accidental or incidental causes during pregnancy and childbirth, or within 42 days of the termination of a pregnancy. And it doesn't matter the duration or the site of the pregnancy. Black women in the United States are 4 times more likely to die from a pregnancy than a white woman. In New York State, that's also the same, 4 times more likely to die. And in a recent article in the New York Times, it was entitled, No Justice Alito, Reproductive Justice is in the Constitution. And this was written by University of California, Irvine law professor Michelle Goodwin. In Mississippi, a Black woman is 118 times as likely to die by carrying a pregnancy to term as by having an abortion. And according to the Mississippi Maternal Mortality Report, this was done from 2013 to 2016, Black women accounted for nearly 80% of the pregnancy-related cardiac deaths in that state. And so Professor Goodwin wrote, the Supreme Court demonstrates a selective and opportunistic interpretation of the Constitution and legal history, which ignores the intent of the 13th and 14th Amendments, especially as it relates to Black women's bodily autonomy, liberty, and privacy, which extended beyond freeing them from labor in cotton fields to shielding them from rape and forced reproduction. The horrors inflicted on Black women during slavery, especially sexual violations and forced pregnancies, have all but been wiped from our cultural and legal memory. And ultimately, this failure is a disservice to all women. I'm sure we all remember in 2020 when there were allegations of forced hysterectomies being performed on immigrants who were detained in the ICE center in Georgia. And there are still others in the abortion opposition movement who want to restrict contraception or birth control. We know that there's scientific evidence to the contrary, but their reasoning is that birth control methods like Plan B or IUDs or pills are abortifacient and prevent implantation of the fertilized egg. So state control of women's uteri is on the docket. It's staying on the docket. And the question we have to really ask is this really a religious movement? Or perhaps is this a subversive effort to try to continue to create a permanent underclass of people who will be so financially strapped and or devoid of rights that they have no other choice but to act in a manner akin to forced servitude. And so what's our obligation? What must we do? I'm the Chief Women's Health Officer, as Dr. LaRocca Arenas said, for New York City Health and Hospitals. And as a hospital system here in New York City, we are absolutely obligated and increasing access, not only to take care of the people here in New York City, but if we start to receive a large influx of patients from other places, we certainly want to be ready and will be ready to accept that influx and keep that access going. Hospital systems that are in states that don't have the protections under their state law to protect abortion access really have to, and this is related to what Dr. Reagan was saying, the hospital systems and the providers in those states need to devise systems to guide patients to where they can receive care, to where abortion is accessible. And certainly, and this is truly scary because I think we all can see where maternal mortality will rise, especially in the states that it's already high and where healthcare safety nets are lacking, that in those states, especially when abortion lack of access is going to impede the provision of life-saving care, these hospitals and providers are going to need to devise safe, fast, and effective transfer systems. Individual providers, doctors need to become aware of pathways so we can lead patients to access, abortion access. And we all, of course, must advocate. So I'm going to leave everyone before we get to the discussion, but for my portion, I'm going to end with the words of Angela Davis, the famous political activist, philosopher, academic scholar, and author, of course, and she's a professor at the University of California in Santa Cruz. I'm no longer accepting the things I cannot change. I'm changing the things I cannot accept. With that, I'll end.
Well, I have to take a deep breath again and thank Dr. Wilcox for ending with that statement, because it is in fact what motivated having us convene and together to see what collectively we cannot accept as health professionals, and that we do not intend to return to the past. But I'm going to actually move forward as I ask this panel to discuss, and I will ask the panelists to turn on your cameras now, but I'm going to lead with the following, which I'm an optimist. So I'm going to lead with what I hope will be a hopeful message. First of all, the hopeful message is we are together, okay? That is important because I think, you know, and I think Kristen mentioned this in terms of, you know, whether health professionals, she wishes she could speak to attorneys all the time, because health professionals need to know history better, need to understand the implication of laws on the patient-doctor relationship, and then need to know how to collectively act ethically moving forward, okay? And I need to address something because it is something that many I have heard certainly expressed as a concern by physicians in terms of the line where research, education, and policy cross over to advocacy. And I think, Dr. Wilcox, you put it correctly, and all of our panelists to say, there are things ethically we cannot accept as health professionals, and it is within our domain to speak and to protect our patients. But the ray of hope is the following. I'm going to read to you the plan that was laid out by Secretary Xavier Becerra following the Dobbs decision, okay? And I'm going to say it specifically and ask the panelists to respond to that and the numerous questions. I did check the Q&A and I have no questions. So audience, I know some of you, 55 of you are still with us. Please don't be shy. We did not do this to hear ourselves speak. We did this because we want to inform, to share information that leads to action to protect the health of women and girls. And we all have women and girls in our families, right? We happen on this panel to be that. I am a grandmother of 2 girls and a mother of a girl, but also of a boy, a man. who's ethically driven. So let me read to you what the secretary said. The plan laid out by the secretary was the following: increasing access to medication abortions. This is what they will do. And what I'm asking you to do as a collective and as citizens, I'll back up. One is vote. It is your duty as citizens. Please vote. Support science and the funding of science, okay? Fellows and members of NYAM are encouraged to join the work group. This is the beginning of a conversation. This is not the end of a conversation. This is the beginning, okay? And we brought to you the legal scholar, the historian, okay? The advocate, the physicians who are here because we want to be informed by evidence as to what promotes health and what is detrimental to health. And this is what they laid out. Increasing access to medication abortions, even though, and I'm reading from the text of the HHS, Health and Human Services, okay? Even though federal programs are legally required to provide medication abortion in circumstances where the woman's life is at risk, or in cases of rape or incest, Becerra emphasized that with the overturning of the nearly 50-year-old right, it's more important than ever to ensure all federally supported programs comply with this directive. Number two, ensuring patient and provider privacy, which is something, of course, that was spoken about. HHS Office of Civil Rights, and this is important because specific agencies are being directed to act. It's not pontificating or just, intellectual, discourse. It is and how to act. The HHS Office of Civil Rights is being directed to ensure that patients and their providers won't face discrimination or encroachment on their privacy for seeking and providing, respectively, reproductive health care. Number three, examining HHS authority under EMTALA. For the physicians and nurses and other health professionals in the room, you know what EMTALA is, right? It is the Emergency Medical Treatment and Active Labor Act, which guarantees the right to emergency department care regardless of insurance status or ability to pay. And violations of EMTALA, I can tell you, are not tolerated presently. They should not be tolerated going forward. Okay, using this precedent, Becerra wants to ensure now that in cases where care is provided to pregnant patients, in particular, those who are experiencing pregnancy loss or complications, if abortion care is that care, that's a doctor's clinical judgment will not be questioned when deeming abortion care appropriate. I'm trying to convey with this discourse to the physicians and nurses and health professionals out there that we have some of the structures in place to move forward, and it requires the courage of all of us to actually act and to not, I think one of you mentioned that the obligation of providers in response to the societal upheaval. This was a word that was used by one of you, okay? This is where we can rely on the evidence and the structures in place. Number four, navigating family planning. All HHS departments are being tasked with ensuring that all health providers, quote, from doctors to pharmacists to clinics, are trained on how to provide optimal family planning care in the post-Roe era. This includes patient care referrals and care navigation, meaning if you cannot provide that care, you have a responsibility to refer patients to that care. Fifth and final, protecting contraception access, which is something that was mentioned. Noting the vital role that family planning clinics play, Becerra stressed here the importance of making sure these clinics can continue to participate in Medicaid, right? And Medicaid is state, what's the word? State implemented, okay? And so this is critically important. Although there are minimum federal standards for family planning care, it continues, those exact services are not explicitly delineated in federal standards for family planning care, regard to Medicaid protection. So that's a point of action collectively, okay? If it's not explicitly delineated in regard to Medicaid protection. Becerra, however, did emphasize ongoing access to emergency contraception and long-acting reversible contraception, okay? He placed great emphasis on ensuring and increasing access to abortion medications, especially noting they are the gold standard of care in instances of miscarriages. So I tell you this so that those of you who are optimists like myself say that, first of all, know what your rights are, know what the structures that exist now to protect your patients, act, encourage, but collectively and with others. And so I throw the question out again. I was hoping, oh, wait, I see there may be a question. Let me see. Yes, I will thank you, the audience, for responding. So one of the questions that is being asked is, can the panelists discuss how this affects men and women as young men who may not be ready for fatherhood may become fathers and that responsibility may be taken away? So again, thank you for that question. I will address it and ask this nuance, okay? We're talking about communities and families collectively. This is not only a woman's problem or girl's problem. So I pose the question to the panelists in whatever order. Please jump in. Just unmute yourself and speak.
Well, I'll jump in. Historically, you know, legal and safe abortions and following Roe, even with all the problems of Roe, this has been a great benefit for public health, decreasing maternal mortality, and a great benefit for men and women, because it meant that people weren't forced into marriages, forced into bearing children that they did not want, weren't ready for whatever reason. And it meant that people could make decisions about their education, about their futures, about whether they stay with an abusive partner. This has been incredibly important for men as well. And of course, most of the time people are talking with their partners or a family member. I'll just say historically, these cases where they're going after somebody for abortion or where a woman has died, they did arrest and prosecute the men who were the husband, the boyfriend, and sometimes the father who's involved. And so men are not protected any more than women are in terms of the law's willingness to go after them. If a local prosecutor or police wants to pursue people for these new criminal laws, the forced birth laws.
Okay, I'm going to go through some more questions to try to get the audience. It's not a question, but it is, I think the panelists, I want to thank you, but this also says, I want to commend all of the speakers for their thoughtful and very informative presentation. I'm so glad I joined and hope many others unable to join tonight will be able to view the recordings. The answer is yes, we have, and thank you to the panelists and to Dr. Perth, who we all agreed that this could be recorded so that others could look at this. And this person says, as a nurse and academic of more than 50 years, I can safely say my eyes were open a number of the legal and practical issues involved. I agree that we need to get out there to vote. This is so much more important than any other issues at play. My granddaughters deserve better. I join you in that as a grandmother, and my granddaughters deserve better. Thank you. Another question is, how can those of us who have experienced performing terminations of pregnancy help those in need? Anyone who wants to respond to that question?
I would say, feel free to volunteer your expertise. We need everybody that we possibly can. And I think it's important to name the fact that regardless, that person, I don't think listed their specialty or their practice, but having everyone at the table is really critical right now. We talked about being inclusive, and I think it's also important to name just briefly that people that are at risk of pregnancy don't always identify as women. And so just also naming the fact, bringing everybody in, and similar with providers, that I'm an OBGYN by practice, but I know that abortion care is done safely in the hands of family physicians, internal medicine physicians, emergency physicians, nurse practitioners, midwives. And so we need all hands on deck. So whoever wants to provide, even if you haven't provided before, there are ways to get trained in things like medication abortion, which often don't involve a lot of hands-on skills. It's more of just being able to provide a medication, just like you can do for anything else. So always opportunities to learn more if you want to provide. And if you already know how, join in.
Great. One of the people posing a question identified that he was a male. So thank you for joining and being on board with us. Okay. I'm going to hopefully we have 5 minutes, and I do intend to finish on time, but let's take a little bit more questions. I'm going to read for some questions that came from the work group. Okay. And this is one where communication and sharing of information may be quite relevant. The question is, as someone raised in a religion that condemns abortion, how do we bridge pro-choice discussions and common ground with fellow members of the same faith that are not pro-choice? Please unmute yourself if you'd like to respond.
I mean, I'll say something unless I'll say something quick and then Wendy Wilcox can. I think one of the things to know is historically and in the present that every single group of every religion, regardless of the teachings on abortion and birth control and sexuality, every racial group, every nationality, every marital status have all used abortions historically and in the present, and usually to the same degree. I mean, things are now, as we were talking about, are very different because of the way income and healthcare and racism has affected it. But certainly, I can tell you, 30s and on, Catholics, Jews, Protestants all had abortions to the exact same degree. So it is a misunderstanding that we've been taught by the churches and the anti-abortion movement. Plenty of people have abortions or know someone who did, or supported it. They don't talk about it.
Dr. Wilcox.
Yeah, I mean, that was very elegantly put, Leslie. Professor Reagan, thank you for that. I just want to say, I think the real problem here is that we're getting the notion that only certain people have a right to privacy. And it's not okay for me to go about my way and do what I want to do. Someone else has to interfere in that. And it's a power move. Like, we can't accept this as anything else other than a power move and a way to subjugate people, in my opinion. And you asked the first question, which was, are young men affected? The last thing we need in certain communities is another reason to have the justice system interfering in the lives of young Black men. They're getting arrested and killed for traffic tickets in some cases. So if you have someone who can't pay child support, is this yet another reason to get them entangled in the justice system, have them land in jail, not able to then provide for their family or be a productive member of society, forever going to be unable to vote? I mean, what systems are we building up here? And they're all intertwined. This isn't just a discussion about healthcare. It's about justice and rights and freedom and everything else.
Professor Sanger, I see you have your hand up. You need to unmute.
There. I did, because one of the comments made me think about, so one of the themes in my book is the absence of conversation among women, in the case about abortions, about having abortions, about planning abortions. I mean, there's a very isolated situation to be in, and there some people have friends, but it was very, very, very interesting how women protected themselves from being exposed, like driving to the next town over to buy a pregnancy test so that the clerk at Walmart wouldn't know she was who was her son's sophomore, classmate, wouldn't know that his mom was in Walmart buying a pregnancy test. I mean, just lots and lots of ways. Or very interesting studies of women in waiting rooms who say, I'm here. I don't want to know who these people are. I want to get away from them. They're no good. I mean, this thing again about my abortion is good, but theirs can't be. I mean, so there's this massive, quite a strong lack of solidarity among women who have abortions. And I've been thinking about that. And I think that's something that needs more collective discussion as well. But the thing about that I wanted to say about privacy, which reminded me of my book, was I have a chapter called Abortion Secrecy, Abortion Privacy. And when I got this idea, I thought, this is a good idea. And here's what it is. A lot of people, well, Tom, did you have an abortion? No, I don't have to tell you. It's my private business. And that's quite true. It is everyone's private business. No one has to, out themselves. But what I realized was some people don't talk, not because they're standing on privacy. They're taking a different form of non-disclosure, which I would call secrecy. And the distinction I would make is you keep something secret when you're afraid you'll be harmed if you reveal it.
Correct.
And so this difference between abortion privacy, I'm empowered, versus abortion secrecy, which is disempowering. I mean, so go ahead. I'm sorry, Danielle.
Yeah, no, I'm looking at the time and I want to pause and thank you for that comment and signal a few things, okay? Because I think I did say we are not ending the conversation tonight. We're just beginning, okay? And solidarity is one of the things that I think we as women, but thank you to the men in the audience and to our communities. This issue of secrecy versus privacy is a critical one that you just signaled. I think one of the things that actually, although I'm an optimist, gives me pause is that we've had in the last, since the murder of George Floyd, the discussion of breaking down, dismantling structural racism, and yet this ruling in my mind is an abandonment of the fact against structural racism because it is structured in the legal system. So we're going to end here because I must. But I really thank the panelists. And I thank Dr. Kurth, who, I've thrown her into the fire peacefully, hopefully, to say that evidence, science, and holding up our professional responsibilities as physicians, as healthcare professionals is critically important. That is what this conversation is about. So we will, I hope the panelists will agree to come back to reconvene. I want to thank Paul Thierman and Allison Squire for the co-sponsoring. Dr. Kurth, if you would come back on, just 2 seconds. It was so good to see your face. And then to tell you that I'm going to say on behalf of these panelists that we commit to supporting your leadership in moving forward in collective action that can apply our science and change the legal framework to protect us, okay? And that is a position, an ethical position of our profession as physicians, as nurses, with the whole gamut. And I will close with that, unless you have some final words, Dr. Kurth, and thank our audience for staying with us. And thank all of the panelists. And please know I'm going to bug you. Now that I know you, and I knew some of you, I'm not going to let go of you because I think it's critically important. But it is 7:34, so we are 4 minutes past. But I thank you for joining us in this important conversation. And vote. Good night.
Thanks so much.